Uh, Good morning. At the outset, I'd like to thank the organizers for giving me the opportunity to do this talk. I'm asked to speak on thyroid. I'm Dr. Shagos, consultant nuclear medicine and PET-CT from Aster MedCity, Kochi. I've been asked to speak on thyroid case studies in nuclear medicine. This in itself is a very big topic, but I'll try to do my level best in the short time that's given to me. Endocrinology is one discipline which uses nuclear medicine to the maximum in diagnosing as well as treating disorders, of which thyroid disorders are the most important, in which nuclear medicine is being used. Nuclear medicine is used for diagnosis as well as treating thyroid disorders, and whereby here what we use is trace amounts of nuclear tracers are either injected intravenously or it's administered orally, and these tracers which get deposited in the thyroid gland from where the rays comes out, and by using special cameras the images are acquired. And usually the normal tracer that is used for imaging is either technetium pertechnetate or iodine 123. In India we use technetium pertechnetate, and which is available from the generator. And iodine 131 is used for treating. Iodine can also be used for doing the scanning. And the mechanism of uptake of both is similar. By way of sodium iodide synthetase, these are transported, present on the cell surfaces, these are transported into the follicular cells where it gets trapped. In case of technetium pertechnetate, it gets trapped in the cells, but it's not organified. Whereas iodine 131 is organified and incorporated into the thyroid hormones. That's a basic difference. In technetium, we inject it intravenously, and after a few minutes of the injection, you can acquire images of thyroid. So the diagnostic indications are, it can be broadly divided into benign as well as malignant. In benign conditions, it can be congenital hypothyroidism, hyperthyroidism, thyroid nodule evaluation, and in malignancies, it's well differentiated thyroid malignancies. Therapeutic indications are basically mainly into two. One is for hyperthyroidism, that is Graves' disease commonly. The other is in for treating differentiated thyroid malignancies. So let's take the case scenarios one by one. We'll first talk about congenital hypothyroidism. It can be either primary or secondary. The imaging patterns vary in each. In secondary causes, usually it is non-visualization of hypoactive glands, whereas in primary, the causes can be many. It can be agenesis, or it can be hemiagenesis, or it can be ectopic thyroid. In each cases, the pattern of uptake is different. You can see this in the tabular column below, given here, what are the patterns of uptake that is usually seen. We'll take for the first case, that is agenesis. This is a child who was diagnosed with congenital hypothyroidism. 72 hours after the birth, the TSH was elevated more than 120. Ultrasound at that time showed reduced size of gland. She was started on thyroxine and the dose was gradually increased. At the age of 3 years, the pediatrician wanted to have an idea whether it has to be continued lifelong, because initial ultrasound said that there was a gland there. Technetium thyroid scan was done. You can see there's no uptake in the normal area, region of thyroid gland. So it's actually a case of agenesis. A repeat ultrasound at that age of 3 years showed no appreciable thyroid tissue. So whenever we evaluate these children at this age group, you always have to do both ultrasound evaluation and technetium thyroid scan, because many times at that age, neonatal period, it depends upon the sensitivity of the probe, the ultrasound can show false positive, or maybe the strap muscles can be wrongly interpreted. Whereas if you do both together, both are complementary in effect, then you can reach a correct diagnosis. The second case scenario here, this is a 5-year-old male Arab boy who was brought to a pediatric OP with short stature, developmental delay. He was wheelchair born when he was seen, large head. Initial TFT, they said, when he was born, in the immediate postnatal period, was normal. Now, at that age of 5 years when he was brought, his TSH was found to be high, T4 was low, and actually the child had muscle hypertrophy, probably related to pseudo hypertrophy. We did a technetium thyroid scan. You can see that only one lobe is present. It's actually a hemiagenesis, and the child had an Herculean appearance due to pseudo hypertrophy. This is Cockray-Debré-Semelin syndrome. So, another scenario, a child, a female preterm baby, congenital hypothyroidism she was diagnosed with. At the age of 1 year, we scanned and we found that it's actually hypoplasia of the thyroid gland. and she was already on thyroxine replacement. So it's all different patterns of uptake that you see in congenital. This is actually hypoplastic gland with low uptake. Incidentally picked up ectopic thyroid, that is, a child was actually 11-year-old when the mother incidentally detected the neck swelling while chewing the food. The patient was not properly symptomatic. She had no constipation, no fatigue, no dysmorphism, no cold intolerance. And so there was a strong clinical suspicion for which the thyroid scan was asked for. And this is a picture that you see. In the normal anatomical location, the thyroid gland is absent, whereas you see another point of uptake, increased uptake here, corresponding to the posterior aspect of the tongue. It's actually a ectopic thyroid, lingual location. And subsequently the child was, so it's an ectopic thyroid. Subsequently the child was started on thyroxine, and once started, they usually tend to shrink. And dyshormonogenesis, whereas, has a different appearance. In this condition, usually this is a 1-month-old baby, and there was a delayed rise in TSH. Immediate delivery postnatal period, it was 8.24 TSH. Gradually it started rising, and then it was TSH was 24.3 when the child was asked for a scan. And this is what you see. For the child, for the age of the child, this thyroid gland looks enlarged in size, and there is significantly increased uptake. The salivary glands usually, which should be seen, is not seen here. So it's an enlarged gland in normal position, which is usually seen in dyshormonogenesis. Coming to the other spectrum where nuclear medicine studies are usually asked for, there is hyperthyroidism. A patient presenting with biochemically elevated T3, TF4 and suppressed TSH. So it can be either due to hyperfunctioning thyroid gland, or it can be due to thyroiditis. This is a case of a 19-year-old female, hyperthyroidism diagnosed in 6 months. She had classical all symptoms of weight loss, tachycardia and everything. No ophthalmopathy was there. And on examination, the thyroid was enlarged, tremors were there. And this is the picture that we got. Both lobes of thyroid, actually you can't even see the salivary glands here. The gland appears significantly enlarged, significantly increased uptake in both the lobes. This is a classical picture that you see in Graves' disease. Subsequently, the patient was started on neomercazole. And in Graves' disease, it's very important to image, because sometimes you see cold nodules. What you can see is, compared to the previous image, you can see that both lobes of thyroid gland are enlarged. And this is the left lobe below which you can see a cold area. This is called a cold nodule. Graves' disease with cold nodule, you need to evaluate them properly. A cold nodule could be due to many reasons. One is colloid nodule. It could be due to thyroiditis, or it could be a non-functioning nodule where chances of malignancy is there. So FNAC has to be done before proceeding ahead with definitive therapy, because we have to rule out malignancies in such conditions. So it's a Graves' disease with cold nodule. Clinically, another patient, same picture, mild thyrotoxicosis, tachycardia, TSH is decreased. The clinical suspicion here was subacute thyroiditis. We did a technetium scan, and on examination also there was an enlargement of left lobe of thyroid. We did a technetium scan. You can see that only one lobe is visible here. This is the left lobe, there's a large nodule with significantly increased uptake, and the other lobe seems to be suppressed. Salivary glands are also suppressed. So it's actually a case of hot nodule of the left lobe suppressing the right lobe and isthmus. Other end of the spectrum, a large diffusely enlarged gland. You can see that both lobes of thyroid gland are enlarged. The total uptake is still very high, 14.7. 1 to 4% is a normal uptake that we see. Here it's significantly increased. So it's a multinodular goiter. It's a toxic multinodular goiter with multiple hot and cold nodules. If you ask me, these patients do not respond very well to radioiodine therapy, because that is one treatment that you usually give for hyperthyroidism, because there are many cold nodules in between, and the size of the gland is also too large. So not much of response will be there to radioiodine therapy. And the chances of malignancy also has to be ruled out by sampling these cold nodules. It's a toxic multinodular goiter. And similar case scenario where biochemically the patient presents with hyperthyroidism, TSH will be suppressed. The other end of the spectrum is thyroiditis. This is what we see here. The patient, a 32-year-old male, presented with weight loss. He was going to gym, so naturally it was attributed to his exercise and eating pattern. There were no palpitation, but tremors were present. He was not on any drugs. We did a scan. We saw that significantly reduced tracer uptake in both lobes of thyroid gland. This is a classical picture that you see in thyroiditis. So same scenario, biochemically hyperthyroidism, but one is increased uptake and this is less uptake, this is thyroiditis. It's very important to differentiate between these two for the clinician because the treatment totally differs in both. The other is anti-thyroid drugs. Here it may subside on its own. The management is different in thyroiditis. So it's very important to differentiate. And low dose radioactive iodine therapy is usually given for treating after once you diagnose it as a Graves' disease, you start them on anti-thyroid drugs for 16 to 18 months. You give them that. If it doesn't subside by then you have to go for a definitive therapy. And those patients who relapse or fail to remit after 12 to 18 months, or those who are having side effects of anti-thyroid drugs, who are non-compliant to drugs, or who opts for non-surgical permanent modality, radioactive iodine can be given, which is given orally, and either as capsule or a liquid form. It is given orally. It's well tolerated usually. Now coming to that was all about the benign condition. Now we'll go to malignancies. The differentiated thyroid malignancies, either papillary or follicular, are the ones that are usually treated with radioactive iodine. We know the first modality of treatment is surgery. After the surgery, then you have to proceed ahead based on the histopathology report. For low risk, it's usually not indicated, but for intermediate risk and the high risk differentiated thyroid carcinomas, we need to scan them, and then subsequently they have to undergo radioactive iodine ablation. The goal of the treatment is to ablate the residual thyroid or any distant metastasis if it is there. And so that for the further future follow-up also, just by doing a scan or a thyroglobulin evaluation, and you can know whether the disease is completely ablated or it is recurrences there, you can pick it up easily. So it is not recommended, but for low risk DTC or minimally invasive follicular carcinoma where there is no angio invasion or capsular invasion, and micropapillary carcinomas, in all these it is not indicated. Let us take case scenarios one by one. The first case scenario is that of a 16-year-old female who presented initially with gradually increasing size of the thyroid gland. FNAC from the left lobe showed papillary carcinoma thyroid. CT-wise, there was a large left lobe lesion with multiple ipsilateral lymph nodes. Multiple bilateral tiny lung nodules were there, which was considered to be indeterminate. She underwent total thyroidectomy plus central compartment and left neck dissection. Histopathology came as classical papillary carcinoma thyroid with lymph nodal metastasis. This is a pre-therapy scan in this patient. You can see that whole body scan, only neck uptake was there. There was not much uptake in the lung fields or anywhere else. These are all physiological uptake in the stomach, intestinal lobes and bladder. Stimulated thyroglobulin was 224 and TSH was more than 100 at that point of time. So based on her age, she was just 16 years. So we consulted, and then we had a close discussion with endocrinologist, and we decided to go ahead with ablating her with just 95 millicurie, considering her age, 16 years. So we ablated her with 95 millicurie. Post-therapy also showed significant uptake in the neck only. There was no uptake in the lung fields or elsewhere. And subsequently, she was kept on follow-up. On follow-up, the immediate first follow-up scan was negative. There was complete ablation of residual thyroid, no distant metastasis. Now she's on follow-up since then. Even after 3 years, she's on 175 microgram per day. Anti-thyroglobulin is 18.3, and thyroglobulin remains. This is unstimulated thyroglobulin in the range of 13. And it remains stable since then. We have not ablated. And here we have not gone for keeping the thyroglobulin well below 10 or something, because it's unstimulated one. If you actually stimulate it, it would be much more. But since she has remained asymptomatic, we decided her to follow up with ultrasound neck and a plain CT chest. She's a medico now, on follow for the past 3 years. And the lungs nodule since then has remained stable in the ultrasound, also stable in the plain CT chest. And ultrasound also shows stable bilateral subcentimetric lymph nodes, and thyroglobulins stable at the level of 13.2. So we have not decided to go ahead with further ablation in this patient because of her age. We didn't want to give her too much, and we decided to wait. Once the disease progresses, either in the scan or by the biochemical values, if anything increases, we then decided to go ahead with further ablation or further decision based on that. So it's not necessary in every patient that you go and treat them so that you may bring the thyroglobulin down below. Based on the case scenario, we can actually take a clinical decision based on your judgment. The second case scenario here, a 64-year-old male, total thyroidectomy, bilateral selective neck dissection and central compartment clearance. Histopathology came as Hurthle cell carcinoma or follicular cell carcinoma with predominant Hurther cell pattern with capsular, vascular, and perithyroidal infiltration, PT3N0. Tumor was found to be infiltrating into the capsule. So, based on the scan reports, we treated him with 3,515 megabecquerels, that is somewhere close to 100 millicurie, because we didn't have the TG values at that time. All what we saw in the scan was the neck uptake. We didn't have the pre-therapy. We didn't do a baseline thyroglobulin evaluation at that time, which was a mistake that we did. Post-therapy scan also showed neck uptake and no distant metastasis. And subsequently, he came for a follow-up. We found that residual thyroid uptake was negligible. Majority of it has gone, no distant metastasis, but the surprise was that stimulated serum TG was 1927. It was very high. Since we did not have a baseline value, we didn't know whether it had increased or come down. So we were at a crossroads there. We didn't. So then we decided to. It was taken as tennis, thyroglobulin elevated, negative iodine, and we decided to go ahead and do a PET-CT in this patient because we had to know where this came from. FDG PET-CT showed, apart from the cervical nodes, we saw bilateral pulmonary nodules. It was FDG away. So it was a metastatic disease. The discussion was there in the tumor board. Because we didn't know whether TG had increased or decreased, we decided to give him the benefit. And because initially we ablated with less than 100 millicurie, we decided to give a good dose and ablated with 200 millicurie of iodine. Subsequently, on follow-up, we found that TG was 573. Repeat FDG PET-CT was done. There was no thyroid bed recurrence, but there was increasing size and metabolic activity of lung nodules. It had not responded. The lung nodules were increasing. So this is between 2016 and 2018. You can see that the lung nodules, this is the cross-sectional image of the lung. You can see that lung nodules here. There is, since from 2016 to 18, it had progressed. Multiple size nodules had increased bilaterally, and TG was also increasing. This was unstimulated. This was stimulated TG of 1,927 in 2016 to December 2019. The unstimulated thyroglobulin was 2,208. He's asymptomatic and has got a good functional status. So the plan is, because he's totally asymptomatic and has a good functional status, we decided, multidisciplinary tumor board, we decided to observe. And the plan is to observe, repeat the TG and TG antibody. And since then, he has gone to multiple premium institutes in the country and taken opinion. And as he's totally asymptomatic, he's a businessman based in Dubai, and he travels to and fro, carries out all his duties. And since then, actually, he's gained weight since then. And as he has remained with a good performance status and totally asymptomatic, we have not decided on any palliative measures. And as of now, the plan was to repeat FDG PET-CT sometime in April. But then Corona happened. We haven't done that. But we are planning to observe if the symptoms related to disease develops. The idea is to start him on tyrosine kinase inhibitors. So tyrosine kinase inhibitors are advised in progressive radioiodine refractory differentiated thyroid carcinomas. And the dose depends upon the need, and also according to the toxicity we'll have to. We have delayed the starting of tyrosine kinase inhibitors here even after 4 years because he's asymptomatic, and we know that these medicines are not without side effects. So we can hold on even in such conditions, even when we found that nodules are progressing. Till the time he becomes symptomatic, we can actually hold on before deciding to start them on tyrosine kinase inhibitors. Case scenario 3, a 29-year-old medico, papillary carcinoma thyroid with cervical nodal metastasis. And he underwent thyroidectomy plus selective neck dissection. The residual thyroid scan showed residual thyroid plus bilateral lung uptake. This was a surprise because it was not known initially. Then we took a CT which showed tiny indeterminate nodules. We asked the history whether it could be some infection then, but no history of prior chest infection was documented. The thyroglobulin, stimulated thyroglobulin was only 9.8. This did not agree with what we are seeing in the lung. So thyroglobulin 9.8 cannot be there with a lung metastasis. Based on this, we actually treated him with only, we assumed that there was only residual thyroid tissue, and we actually treated him with only less than 100 millicurie of iodine. And the follow-up and post-therapy scan also showed neck uptake and significant uptake in the lung nodules. On subsequent follow-up, actually we were proved correct because Residual thyroid has totally gone. All these lung nodules had disappeared, and thyroglobulin was actually less than 0.2 stimulated. So even though the lung nodule uptake was there in the initial pre-therapy, as the TG was not very high, we assumed that it could be because of some undiagnosed infection, some other causes, and we treated him according to what we went by thyroglobulin and thyroglobulin values and treated him with less than 100 millicurie, and follow we have achieved complete ablation with thyroglobulin well below it's only 0.2 nanogram per ml. And another rare case where a 29-year-old lady, a nulliparous, recently married lady, presented with pain in the right iliac fossa. Investigation revealed bilateral complex adnexal masses with peritoneal deposits and ascites. She underwent open bilateral ovarian cystectomy, and histopathology was reported as struma ovary with multiple peritoneal deposits consistent with highly differentiated follicular carcinoma. Ultrasound neck was done, it was normal. Thyroid function showed mild hypothyroidism. She underwent radical surgery, but fertility preserving surgery, PSO plus omentectomy plus stripping of peritoneum, but uterus was left behind. Subsequently, she was treated at the same go. She underwent total thyroidectomy also because it was metastatic, and we had to, if we had to go ahead with treating with iodine, her thyroid had to be out. So she underwent total thyroidectomy also in the same sitting. Histopathology revealed struma ovary with extensive extra ovarian metastasis, thyroid consistent with highly differentiated follicular carcinoma, but thyroid histopathology, there was no malignancy, it was normal. This is a pre-therapy iodine scan, which can show that small amount of residual thyroid tissue is there. All these uptakes that you see in the abdominal quadrants are abnormal. These are all the serosal deposits that we are seeing here. And her stimulated TG was 70.5. So based on this, we ablated her with 6,475, more than 100 millicurie, around 150 millicurie we gave. And post-therapy scan showed significant uptake in the thyroid and all the serosal deposits. And before undergoing all the radical surgery, because she was nulliparous and newly married, she had undergone fertility preservation surgery here, and she had undergone cryopreservation of embryos also because she wanted to conceive after once the treatment is completed. So this is a post-therapy scan, extensive deposits, significant uptake is there. Follow-up scan after 6 months showed complete ablation of the residual thyroid tissue. All those serosal deposits have disappeared. No uptake anywhere else, complete ablation, and stimulated TG was only 0.7. So with one sitting, because total thyroidectomy was also done, we could ablate her with radioiodine and achieve complete successful ablation. To a word about FDG PET scan, very often we pick up incidentallomas in PET scan. Ask for some other causes. The pickup rate is 0.2 to 1% or something. And many times when this incidentallomas are picked up, we ask for ultrasound correlation. And around 30% of malignancies have been reported in literature in these incidentallomas that is picked up during FDG PET. This is a case where a patient presented, an elderly lady presented with backache. Evaluation revealed a lytic lesion in the lumbar vertebrae. She was sent for PET scan as a workup for unknown primary. We saw lytic lesion in the L4 vertebra. Apart from that, what we saw is a small nodule in the right lobe of thyroid gland with a focus of calcification. And truly, the biopsy came as follicular carcinoma thyroid with capsular invasion. Subsequently, she has undergone thyroidectomy and ablation. So to summarize, nuclear medicine is an invaluable aid to endocrinologists in managing thyroid disorders. It can be used for diagnosis as well as therapeutic purposes, both in Graves' disease as well as differentiated malignancies. Multidisciplinary management, including the surgeon, endocrinologist, and nuclear medicine physician, holds the key in properly managing these conditions. Thank you very much.